Excellent. Thanks again, Jim, and thank you, Vita, for this wonderful opportunity to do this webinar with you guys today. Now, so today we're going to talk a little bit about getting proper planning and proper restorations for implant-supported cases. Now, if you guys are interested, here's a new QR code. I tried to use my old one at the previous presentation. For some reason, it just wasn't working, so I've updated it. If you guys scan this QR code, it takes you to all the links that I have, my personal information, my social media contacts, a link to my Thingiverse account where I have those STL files for you guys to download, things like this. And as always, if you guys have questions, don't hesitate to ask, whether during the webinar or after the webinar. If you get this QR code, then you can always message me on my social media, and I'll try to help you guys as much as I can. Okay. So, as with any case that you're going to be working on, implant supported or implant retained cases, if you don't plan things properly, guys, it's just, I can't stress this enough. I do this webinars and lectures quite often, and this one thing that I try to push so much with everybody, and I try to explain that the initial planning is one of the most important things that you can do for your case. Just as an example, yesterday I was doing a retread on a case for maxillary hybrid, and I started taking the case apart, and I could see there's just no room there at all for all the components that I try to fit in, and that caused some issues, which I'll talk about a little bit further down. So proper planning would have solved these issues, and we wouldn't have to deal with it right now. So whenever you have a patient that's presenting, either they have some dentition or they're fully edentulous, things need to be planned according to what you can do for this particular patient. Now, you generally will subdivide, if patient's fully edentulous, you'll subdivide into 3 categories: mild, moderate, and severe. And for each one of these categories, you need to use a specific type of prosthesis in order to give your patients what they need. Okay. Now, when you're dealing with a mild defect where it's just dentition that you're replacing, maybe a little bit of gum somewhere, you're going to be doing something like a Columbus bridge in these cases, or, if you're partially dentate and partially edentulous, you're going to do some on implants and some on dentition, but it usually ends up looking something like this. In my opinion, this is one of the harder restorations to accomplish, because you're not just dealing with just stick a bunch of teeth in there and be good with it. You have to, from the clinical standpoint, you have to address every single papilla for this particular patient. And clinically, it can be very, very challenging. Not to say that on the laboratory side, it's a piece of cake, but clinically, it can be quite problematic in order to make it look good as well. Okay. This case was sent to me, actually, pictures were sent to me by my buddy in Greece, Demetrius, and he does some amazing crown and bridge work. Now, for moderate defect is when you're missing enough there to either do a traditional hybrid restoration, where you have a wraparound acrylic, or you can do a full arch zirconia or some other materials, or you can do a overdenture type where the full flange is present. And those cases are generally done dependent on how much of a smile line you can see. So let's say, for example, you want to do just a regular screw retain hybrid restoration, but the patient's transition line, as you can see right here, is not where it is right here, but a lot lower. And the patient, let's say, for example, has a very high smile line. So if you don't do it properly and you end up doing just a regular hybrid, every time the patient's going to smile, you're going to see that transition line on that patient. So for those patients, it's very important to provide the proper type of restoration. So for patients with a very high transition line, one of 2 things could be done. One, we can just change the type of restoration to a overdenture. It could be a bar overdenture, it could be locators, depending on what you want to do. Or you can do more bone reduction while you're planning to move that transition line up higher in order to give your patient a screw retained hybrid, per se. Personally, if it was me getting this done, I would probably go with an overdenture versus a hybrid for a couple of different reasons. Major one for me would be hygiene. Hybrids are notorious for being problematic when it comes to cleaning. With overdentures, it's generally not an issue because you can remove it yourself, you can properly clean them, and get them put back. Also, when it comes to repairs, overdentures are a lot easier to deal with because you don't have to unscrew the whole thing, right? If you chip a tooth, you can always just take this whole thing out, send it to the lab, or do it during their chair side and put it back in. So it's a lot easier to fix. With hybrids, you have to drill out the composites, unscrew the whole thing, send that out, bring it back. It takes a lot longer. Okay, when you have a severe defect, right, not just vertical but also a horizontal defect, so where you have a lot of deficiency in the lip support, something you should be doing probably is just doing a full flange overdenture, because you need to build up the space that was completely lost, so you have to rebuild it completely. Okay. Next. So I'm going to show you guys a case which is not a clinical case, but it's like a demo case. And the reason why I did a demo case, it just made it a little bit easier to follow the pictures. But the same thing goes pretty much for all the clinical cases as well. So for your initial planning, let's say you have a patient that presents either fully dentated on the mandible, or you got a full denture on the mandible, or you have a implant supported or retained denture in the mandible. On the maxilla, the patient's fully edentulous. So where do we start? How do we go from here? What I basically do is just follow regular denture protocols, guys. So you take a regular initial impression with alginate or alginate substituted like you see here. Then you make a custom tray. Whether you do analog custom trays with tissue stops or analog trays with no tissue stops, perforated trays versus non-perforated, I'm more of a fan with non-perforated. And nowadays, I do most of my custom trays digitally with tissue stops, a close fitting tray. As long as you have a good impression, it doesn't really matter how you get there. When I first started out doing this, I was very black and white kind of person. You know, like either you do it this way, you don't do it at all. But I've found out over the years that there's lots of ways to skin a cat, so to speak. And by creating the custom trays, either which way, or even using a modified stock tray, as long as you get a good impression, I'm fine with whatever you guys are using. Okay, so custom tray, final impression. Like I always say, I do really good custom impressions, or I do really good final impressions as long as there are no patients involved. And from here, we do a regular wax rim, send it for a bite registration. Preferably, guys, when you're doing these steps, do a Gothic arch tracing, especially if you're going to be doing implant supported restorations down the line, because little changes in the bite when it comes to tissue supported are not as problematic, because you can, reset things, you can jump a case, make a whole new denture. But when it comes to implant supported down the line, if your bite was off and then all of a sudden your implants are more anterior than they needed to be, and then all of a sudden you have access holes and things like this coming through the interiors of your teeth, and you don't have enough room for the teeth, and you end up with microfractures. So I try to stress this point to make sure you get everything properly fabricated in the tissue supported until and not move forward until you have everything rounded out and your bite's stable with tissue supported. Don't move towards the implants, guys, because I see a lot of times we'll end up doing an immediate denture, and at the same time we'll use that immediate denture for surgical guide, which is a valid protocol. Don't get me wrong, a lot of people are doing this, and I do it myself. But how often do you guys see a case that we had done immediate full upper, full lower, and the bite has changed within the 2-week period after the surgery, and we need to change stuff around? I need to adjust the bite, or we need to redo a denture. Things like this happen. So in my personal opinion, I would rather put a patient in a temporary immediate denture, make sure everything's great aesthetically and phonetically, and after that, after everything's kind of been dialed in, then go towards the implants. But I understand we can't always do that also. Okay, so from there, we're going to do a try-in, make sure everything looks good, and then we fabricate a temporary full denture. Okay, now that can be used for conversion down the line, or if you're me and you want to go things correctly, you're going to have this patient wear this for a while until everything stabilizes, at least a couple of weeks to a month. Okay, remembering how much space certain things take is very important when it comes to fabricating implant supported restorations. And most of you guys have seen this picture. I've posted this a few times. I've used it in my lectures a few times. But to me, this picture never gets old because there's a certain amount of room that's needed for the materials to be fracture resistant. In most of the cases, when it comes to bars, you want your bars to be 3 to 5 millimeters tall. At the minimum, you want it to be 3 millimeters, obviously. Now, if you have a lot of room, don't completely cover that entire area in the bar just because it gets a lot of strength. Because acrylic also gets its strength from bulk, and you need a minimum of 2 millimeters of acrylic all around the bar so you don't get microfractures. And if you don't have that, as I was seeing a case the other day I was telling you guys about that I'm doing a retread on, we had like less than a millimeter of acrylic on the gingival side, on the integral side of the hybrid. And you can see microfractures throughout the whole thing, and where bacteria and everything else would leak in there, and then it could cause some interesting smells for sure. Okay, as far as the tooth is concerned, on the interior you want to have 4 to 7 millimeters of tooth, because if you don't have that, well, basically what happened is that if you, let's say for example, your tooth is a lot shorter and the acrylic from here ends up reaching to about right here, and you only have like 2 to 3 millimeters of the incisal edge that is showing, that will mess up your patient's speech because they're going to have a bunch of stuff right behind their teeth and they're going to have a really hard time talking. So that's important, not just for the strength, but also important for a proper speech, guys. On the posterior, we're looking at the same thing, except the height of the tooth could be a lot smaller, right? We could be at 3 to 4 millimeters if we need to be. But the bar height and everything else remains the same, guys. Now, if you're not doing a hybrid, if you want to do some kind of type of other restoration, either just doing a basic locator case, or you're doing a bar with locators or a bar with some kind of other locks, each component has a certain amount of room that's required in order for you to stack everything up. So for my bars, regular hybrids, I usually require like 60 millimeters to bone level for bone reduction when we do things so we can stack stuff up, as well as making sure the transition line is going to be below that line, right? So we don't see that that area. So, I mean above that line, above the lip line. For here, you can see a drawing that I did. Kind of, I don't have the best drawing skills, obviously. Even the digital ones kind of suck a little bit. But if you're doing some kind of bar, you want to make sure that you have enough space underneath that bar for cleansability. I see very often if we do bar retained over dentures where the bar is fitting really close to tissue and underneath the bar is kind of rough. And a lot of people think like if you get it really close to tissue, food won't get impacted underneath it and cause inflammation and bone loss. That's not true. I mean, I've seen things pretty tight to the tissue, and food and bacteria still gets impacted underneath it, and you'll see tissue inflammation and bone loss down the line, and then inevitably you're going to have cleansability under the bar, but you also end up losing some bone around the implants, which could be very dangerous. The bar height remains the same. If you're doing locators, locator components require about 3.5 millimeters for locator and cap. Also, when you do locators on the bar, I very highly recommend doing a secondary structure, which takes up some room, and then you have the same acrylic and the tooth thicknesses to go on top. This next picture was given to me by my friends at Preet, and it's a very nice picture that also talks about the biologic widths and everything else. And the very funny thing that they say right here, biologic width varies. That is very true. Depending on where what you're working with, a lot of times, especially on a maxilla, I'll show you in a few slides down the line. If you're dealing with a Kaelin combination syndrome case, your biologic width of your gingiva is going to be way different than what you see right here. I'll show you that in a minute. Okay. AP spread, guys. Very important concept also to follow. It's not the most straightforward thing in the world, and it's not an iron rule. You don't always follow it exactly to the T. Sometimes you change it. The way you measure AP spread, which is anterior posterior spread, you measure it from the center of the most anterior implant to the distal of the most posterior implant on each side. So as you can see, on this side, it's a bit shorter than it is on this side. So we can cantilever this 1.5 times this distance in cases where you have fairly decent bone support, in cases where you probably opposing, let's say, a tissue-supported or implant retained denture. Now, if you're opposing fully dentate mandible and the patient's like a 40-year-old linebacker with huge muscle mass and a bruxer, then maybe I wouldn't do 1.5 AP spread. Maybe I'll do 1. Or in some cases where the bone quality on the maxilla is not the best, maybe I'll do less than that. Okay, maybe I'll do half in order to minimize stress on those implants and so I don't cause bone loss and implant loss down the line. But if I have a patient who's like a 90-year-old lady that's got no muscle mass and barely eats mashed potatoes, right? And she's opposing tissue-supported denture in the mandible, then I have absolutely zero problems doing an AP spread of 1.5 or even a 2 if I need to, because I know there's not going to be a lot of forces that are going to be exerted on the opposing. So everything is very individualized, guys. You have to approach each case and you have to see what you're working with and what you're dealing with. Okay. Transition line we talked about already, guys. Very important part, especially if you're doing a hybrid type of restoration. You want the transition line to be above your smile line. Okay. So when the patient smiles, you don't see that little change from the prosthesis to the gingiva. So that's a very important aspect to consider. So when you're planning things, if you have a denture, have them smile really, really wide, or just, as wide as they can, or make them laugh, or record them on video making them laugh, and you just measure that distance doing a screenshot. So don't make the same mistake. We've made this mistake a few times, guys, and it just becomes a nightmare down the line. Okay, this is where the transition lines are, right? You have the denture that ends here, and you have the gingiva that begins here. So you want to make sure your smile line is going to be below that, okay? Because if it is above that or at that line, you're going to see that it's not very pleasant, okay? Once you fabricate that denture, once you measure everything, once you know what things are going to be doing, and you decide, okay, let's say, for example, I got a moderate defect and I want to do a hybrid. Well, we need to plan for proper bone reduction and we need to plan for proper implant placement. Now, there's several ways you can do surgical guides, and not surgical guides, I'm sorry. Several ways you can do scan guides, guys. You can either just scan the denture in, print a clear replica of it, and put a bunch of gutta percha markers, as I did right here. The one thing I didn't do correctly is you want to make sure these are kind of staggered all over the place, and you want to have them not just on the palatal and lingual, you want to have them on the facial as well to orient things a little bit better. Okay, so you want to use some kind of radio opaque material. You could just put zirconia bits right on the surface of the denture and attach them with a little optiglaze that holds it in pretty well for the time being, and use that as your scan. Or one other way, what you could also do, there's 2 ways to do a CT scan for your patients where you're doing planning for surgery. Now, there's a dual scan protocol and there's a single scan protocol. Dual scan utilizes what I showed you previously, right? Where you got like a duplicate denture with scan markers, or you put scan markers on a denture with like beads, or you use stickers. I think I have a picture. Yeah, these SureMark stickers. That's what we've been using as of lately. Patient comes in and they have a really good denture and it fits well. We're just going to use the SureMark stickers to do that double scan protocol. So the way the double scan protocol works is that you basically scan the patient with a denture in the mouth, And then the second scan is you change the settings of the CT scanner to pediatric scan, and then you place the denture on the foam block that sits on top of that little room where you do the scan, and scan that. And you can overlap those two scans together and get a much better presentation of what the denture looks like in the patient's mouth. Okay. And what it basically looks like is something like this. Okay. So you have your denture with your, these are actually short mark stickers that goes in there. And we have the patient's mouth slightly open, just so we could see really well what's going on. And a lot of times we'll put like cotton between the dentures, and we'll put cotton on the sides so the tissue doesn't interfere as well a little bit. But this is what it typically looks like, guys. But for something like this, where you have teeth that are made with some kind of a radiopaque material, like in this case, I actually mixed in some barium sulfate into the acrylic. These are done with a single scan protocols, where you just put the dentures in, scan it, and don't scan the dentures afterwards. I don't like doing it this way because it creates a little bit too much noise, in my opinion, when you do CT scans. So I'm a big fan of doing a dual scan protocol. So when you've done it like this, when you marked it and you scanned everything in, a lot of people will just use this um, and convert that file. So the secondary scan of the dentures, they'll convert that file into an STL and use that for the surgical guide. Some people think that you can just do the secondary scan without doing the secondary CT. So what I mean, like when you do your initial CT scan of the patient with dentures in, the second one you do of just the dentures themselves. So you pretty much usually have like 3 scans, one like this, one of the maxilla, one of the mandible. I had some residents who thought that if they can just scan the denture 360 with their intraoral scanner, they'll work the same way to align things. Yes and no. Oftentimes, depending what kind of sticker you use, the bead will be on the inside of the sticker, which will get registered really well with the CT scan because it works with contrast, right? But on the intraoral scanner, it will just scan the top of that sticky portion of that, top of that scotch tape, okay? And you don't have the actual outline of the marker. And to align those two things together could be quite a little bit problematic. So if you want to do that, then I recommend you guys do a regular CT scan, a scan for each of the dentures. And if you want to make things easier for your lab, then do a 360 scan of each of the dentures and save it as STL and send it to the lab, because it's a lot harder to convert a CT scan file, which is a DCM file, I think, into an STL file. So when we talk about biologic width a little bit earlier, right? So we measure how much gingiva we have, and we measure from my bone levels and stuff like this. This particular case patient had Kelly combination syndrome, and usually with Kelly combination syndrome, you're going to end up with hanging tuberosities, because what basically happens is you have a full upper denture, and you have a lower partially dentate canine to canine, usually with a lower partial. And oftentimes patients don't wear their lower partial, or their partial needed to be relined or something like this, and they put a lot of forces on the anteriors, right? And that causes that rotational force of the maxillary denture, causing some suction in that area. And that causes that tissue to hang down. So when we say usually the tissue width is 2 to 3 millimeters, well, in this case, tissue width is 9.2 millimeters. So when we do in bone reduction, we need to look at things and go, okay, so if we need to be at 15, which is what, about right here, so that I know that only about 3 millimeters of that needs to be bone, and the rest needs to be quite a bit of tissue reduction, so I can accommodate for that space. Okay, hope that makes sense, guys. Okay, if your denture that your patient shows up with is not well fitting, let's say he likes the bite or she likes the bite, the aesthetics are great, but the denture kind of flops around a little bit. Make sure you use some kind of radiopaque reline material when you do the CT scan, so you can see good adaptation to the tissue and its relation to the bone, because otherwise it's not going to be precise, and you can run into some issues doing that, guys. So what was taught to me and what I recommend is using green mousse. This stuff is nice and radiopaque, and it works pretty well to do those little chairside relines for the purpose of doing a cone beam CT for your patients. Okay. Now for surgical guides, guys, once we have that file scanned in, either I scanned in the actual duplicate denture the actual denture that I fabricated and made a duplicate denture, or if the patient has a denture and a doctor sent me a scan, from this I will generally make the surgical guides. I don't do very often fully guided cases. I've only done one or two. And we've had better success with my prosthodontists and my oral surgeons doing a duplicate denture guides. It's just been working well for us, so we've kind of been sticking with it. What basically we'll do is I'll duplicate the denture, and in the olden days I used to just do it duplication by hand. And nowadays I do it printed. So this is a case that came in and the doctor took a duplicate of the patient's denture, used that to take a wash impression, and you can see they opened up the patient's bite and they wanted me to make a whole new denture and a surgical guide right away. So that would deliver that and do the implant placement. Well, what happens when you change the bite like this, which is pretty drastic, and you do it very quickly? Patient doesn't have time to get adjusted to it, so the bite might actually shift from that point, which is exactly what happened here. So when we went to do permanent prosthesis, it ended up being a problem. So what I recommend to you guys, if you have a situation like this, fabricate this denture, no problem, but have the patient wear that for a while. Make sure the bite's adjusted, then maybe remake it if you need to, and then use that to do implant placement, okay? Because if this is a class 2 right now, all of a sudden the patient's actually class 3, or class 1, and then now they are class 3 or maybe class 2, then it's a whole different story for implant placement, guys. Okay? What if you have a case that looks like this? Patient has an existing denture they've been wearing for a while, the vertical has collapsed, and the patient has an acquired class 3. Can you use that for planning of your future dentures and use that for planning of your future implant placement and surgery? No, you can't do that because this is not their proper occlusion, this is not their proper vertical, their proper aesthetics, and their proper function. So you want to restore them to that first, up to a certain point, obviously, and then and only then do the surgical guides and everything else. There's many ways to duplicate dentures, as I showed you guys. In the days before intraoral scanners were used as commonly as they are now, and before I had a lab scanner, we do stuff like this. We could even use like a soap dish to make a duplicate impression of the denture. Cases like this, guys. Can you go from here straight towards the thing? No, don't go directly from there. I mean, look how much we opened up that bite. Basically what we did, we duplicated the denture, and then we just would add a little bit of a bisacryl layer day by day or week by week to bring the patient's vertical back to where they were originally, which is about right here. Okay, and then you fabricate a denture, and then you have them wear it for a while to see how well they tolerate it. If everything's okay, or maybe we need to close that bite up again a little bit, maybe they can't tolerate such a huge opening, then and only then you should do implant placement, guys. Okay, just another way to duplicate by hand. This one was using alginate, which I'm not a fan of. But this is also another view of a surgical guide. So there's a trough that we generally place from the middle of the posterior teeth going palatally and right behind the anterior teeth going palatally, and give that trough to the doctor, which is an approximation of where the implants will go well according to the prosthesis. And this line right here, I've changed it a little bit since then. I used to just do this window, but a lot of times doctors would question and go like, well, do we go to the bottom of the window or the top of the window? So what I started doing as of late, I just started cutting it to about right here, so they know this is the only place to cut to. Okay. And when you do fully guided cases, they work well as well. But the problem is you have to do a much deeper flap. So because these are played directly onto the bone, not on the tissue, and these a lot of times are stackable. They work great, but they haven't worked great for us, or as great for us as we were hoping to. So we decided to stick with the old method, and because they've been working so great for us so far. Okay, so as you can see right here, this is the one we did for a patient for locator cases. So usually for hybrids, we'll measure from here to here at 15 to 16 millimeters But for locators, we will do 12 millimeters. Okay. And on the inside, you can see that I showed them where would be ideal position for the implants. On this one, they placed it a little bit too close to that tooth, but still not too problematic. We actually loaded those locators up not too long ago, and everything went fine with no issues. As you can see, I oftentimes will make this area right here wider on the surgical guides, just so if we need to flap the tissue a little bit more, it has room to where we can move the tissue out of the way without causing any issues for the patient. And the cut from here, you can move the tissue that way as well. So it has been working pretty well for us. Okay. And surgical guides, especially if you're printing them, well, that's one great thing about doing them printed versus doing the old acrylic way. You couldn't sterilize the acrylic ones. You could do cold disinfection, but you couldn't put it in the autoclave. With this stuff, I'm using pack dense surgical guide resin, full autoclavable with no issues. So I've been using that quite a bit, and I like it a lot. Okay. So when you have placed your implants according to your duplicate denture, and hopefully by that point your patient wore that denture for some time in order to establish their proper occlusion, phonetics, and aesthetics, and they're completely happy with it. Now you place the implants. Now you're going to use that denture or duplicate of that denture to convert to a to an implant retained immediate load restoration. Why it's important for me to have a fully fabricated soft tissue supported denture that has proper borders and proper suction, because sometimes we're not able to load the implants, and sometimes we have to do like a tissue supported prosthesis. Or what we do now, if we can't load the regular implants, we'll put a couple of mini implants in there and load those up on a fully flanged denture. I have the patient wear that until the other implants integrate. But let's say, for example, everything torqued normal, we have placed the implants and we want to do conversion chairside. Personally, I don't do any kind of conversions chairside because it just didn't end up being a good fit for me. A lot of people do a great job doing that, and they make a business out of it. My friend Dora in New York, she does a wonderful job doing conversions, and it's all she does. Me personally, I've done a couple, and I felt like I wasn't a good fit with it. So I'm going to show you how it's done, but I'm not an expert on this. So I suggest you guys would listen to somebody like Dora and those guys who are really good at conversions. The way I do conversions is just pretty basic. We usually work with multi-units. So put a couple of healing caps on there, place some butter registration blue mousse into the denture, mark the areas, and I'll just cut those out of the denture. Then I'll adjust the height of the temporary titanium cylinders so they're not interfering with occlusion. Now beware, the titanium cylinders have a certain height. If you see that you have to cut a lot from there, this is actually one from Dora. That means your surgeon probably didn't do enough bone reduction, and that's going to cause you some issues down the line. So cutting a little bit is okay, but if you're like cutting, there's barely any of that tie base left, then you understand that you probably don't have enough bone reduction. So once I have everything cut, I'll protect the area with some rubber dam. And as you can see, you want to make sure those holes are big enough to where it's not touching the acrylic anywhere. In this case, it's touching it here. You might want to adjust it a little bit more here. And then you either, if the patient is semi-conscious, you can have them bite down in the regular bite. But oftentimes I like to have some kind of splint pre-made so I can kind of guide them into the occlusion a little bit better. But oftentimes with these immediate conversions, guys, bite's still not going to be the best, and it will need to be adjusted. Okay, so it looks something like this when you pick up the cylinders. Now what you basically need to do is you need to cut everything back. Make sure you don't have any cantilevers. Like half a tooth is okay, but even in some cases, people will actually cut that part as well. And then you want to make sure that you reduce your cusp height on your dentures, because you don't want to have too much lateral forces on your implants while the patient's functioning, because it could lead to implant loss. What we generally do is we'll make sure there are no cantilevers. We'll reduce the cusp height, and we'll put a patient on a soft diet, okay, to make sure they don't eat anything hard My prosthodontist tells them don't eat anything harder than boiled fish. And that usually works out pretty well. When you're doing your conversion, guys, it's important. I'm going to click on that slide a little bit later. It's actually this slide, guys. But when you're doing your guys' conversions, if you have a soft tissue area, make sure you kind of smooth it down so the denture will actually push on the soft tissue, making it like a tissue form. Because this is the best time to do that. Because if you try to do it with a final prosthesis, it's going to be problematic. So when you're doing with the immediate denture, make sure you create nice pressure on that area so you have a flat tissue surface or you have a concave tissue surface, and making the denture the flat or convex and making it way more cleansable. So that makes it very important to do that. Now let's say, for example, you want to do something in the lab and not just chairside. Let's say you want to do some kind of reinforcement and you don't have the time right there chairside to get that done. What you basically will do is you give a patient a duplicate denture to wear for a couple of days while you're working on this, and then you're going to use your surgical guide as an impression tray, like a custom tray. And I prefer to use a thicker material to take that impression because you want to avoid stuff that runs all over the place because you don't want to trap those sutures. A lot of times we'll put a little bit of Vaseline on the sutures so they don't get trapped. But even with all of that, we end up every once in a while ripping a couple of sutures off while doing that and have to go back and resuture it. Okay. So we pour up an impression from that point, and then we also need to get that denture in the proper occlusion intraorally transferred onto the model. So basically the same thing we did before, make the holes, pick things up, and everything else. But for this, you don't necessarily have to pick up all four. You can just pick up two because all you need is enough information to transfer that onto the model. And a lot of times you're going to have to do a lot of grinding because the tissues areas are still kind of swollen and the prosthesis is not fitting all the way down. So you might have to cut a bunch of areas on the prosthesis. So as long as you have that occlusal part there, that's all you really need, and make sure it's attached by two implants. Okay. Same thing, bite. So when you get to the lab, you can transfer everything, and you can actually have the setup transferred as well because you know which teeth you used for the denture, and you can just have another order of teeth ready. You can just put it into the bite registration. And from here, you can reinforce your hybrid, temporary hybrid, a couple of different ways, guys. One of them is to use this fiber force rope. The method that I personally like to use is using what's the name of this stuff? My goodness, I can't believe it just spaced my mind. It's called Trilor. There we go. Trilor. It's sold by Harvest, I think. In Canada, I think it's sold by Swiss NF, and it works really well. And what's great about it, it comes in little arches, and you can just cement them to the temporary cylinders, and you can shape the arch by hand with your handpiece. And they're really, really strong, guys. So I love using these for temporary hybrids, and we've used them for actually long-term temps as well, like really long-term. I had a patient that was like in their 90s, and they're like, well, let's do something that's going to work for them, but it's not going to cost a ton of money because they're obviously, I wish them all the health, but they're not probably going to be living for a very long time. So we did something like that for them, and it worked out wonderfully. Okay. And then you just do a setup on top of that. And then, like I mentioned before, this is the best time to adjust the tissue. So you're pressing on it, making sure you form the tissue where it needs to be. We just adjust it with one of these kind of wheels. And then we process the temp and send it, and the patient wears it until everything integrates. Okay. So we went through the process of planning things. We went through the process of scanning stuff, creating surgical guides, making all this stuff, placing the implants hopefully in the right position, giving the patient a temporary denture to where now it's been 2 months to 2 years, depending on what the bone quality is like. When you have a thinner bone, not thinner bone, but less dense bone, let's put it that way. Implants sometimes take longer to integrate and they're not as strong and things like this. So you want to wait as long as possible before loading them so you don't end up losing implants. Okay. On maxilla, obviously, the bone's going to be less dense than on mandible. And what I've learned the other day, actually, super dense bone is not always the best thing. And the reason for that is because when you have so much density to the bone, a lot of times you don't get the proper blood flow, and integration of implants is a little bit compromised. So too much of a good thing is not always a good thing. Okay, so let's say we have that temporary denture the patient's been wearing, and they either like it or they don't like it. So on these kind of cases, if they don't like it, we won't replicate this. But if they do like it, we'll replicate what the patient's wearing. And I'm showing you a couple of different ways. So let's say, for example, we're just going to start from the beginning. We're not going to duplicate this denture in any way. So basically what we're going to do, sorry guys, is we're going to, my mistake, my apologies. I clicked something wrong. Okay, so because I deal lots of times with residents who are fresh out of dental school, I try to make things a little bit simpler for them on the clinical side, but I will complicate things on the laboratory side. So basically, I don't know if you guys can hear this. My dog is going crazy because somebody's at the door. I will put in the closed tray impression copings because it makes it really easy for them to take an impression because they don't have to modify the trays so much. So that what they basically will do is we'll use this, take the impression, and then in the lab we'll take those impression copings, put them back in the impression with analogs, and we put things up. Now this to me is not considered a final impression, guys. I look at this like I would at an alginate impression for a denture, okay, which would be a temporary thing. And from here, what I would do is I would make an impression jig, not a verification jig, but impression jig, because I have a lot of doctors, what they will do, especially prosthodontists, they'll put impression copings, like open tray ones, not closed tray ones like we did, and they'll tie everything together with some floss or some orthodontic chain, and they'll put a bunch of composite there to hold things in place, and they'll take a final impression. For residents, it's a little bit too complex, so I make it a little bit simplified. So I'll use this initial impression. I'll make a little jig with some pattern resin and some floss, as you can see right there, and I'll slice it for them, and I'll mark it for them, and I'll make it in a custom tray. So all I have to do in the clinic is just put that in place, glue those pieces together, because I make them nice and thick. Because if you're doing it chair side, intraorally, it's very difficult to control the thickness a lot of times, okay? And I'll load everything together with jig gel or something that's close to it. It's a low expansion or low shrinkage, I can't remember which way it goes, composite that is pretty precise. And this is what happens, guys, if they try to do this chair side without fabricating that jig. Oftentimes, just because they're just connecting everything, material will slump and you'll get areas that are pretty thin and can offer some flexibility, and sometimes things are not very passive. It's important to do passive things when you're dealing with implants, because if you don't have complete passivity, your restorations will not fit, or they might fit with some areas that are a little bit more aggressive than the others, causing undue stress onto implants, causing implant loss down the line. So it's very important to have things very passive when you're doing implant-supported restorations. Okay, we'll see cases like this where they'll use a stock tray to pick stuff up. I've had some success with these and had some failures, so I can't really go one way or the other on them. But whatever works, guys. That's all I can say. Now, the other thing that I like to do, if you don't want to do anything chair side, and you want to make things less complicated, like by connecting stuff, what I basically will do is I'll make one of two ways. I'll make a special metal verification / impression jig for my cases. Let's say, for example, I have a doctor that already took the final impression and sent it to me. I can pour that up and make a verification jig out of this, send it back to them, and they can try it in the mouth. And if it's not passive, they can just grind the composite that holds it together, this stuff, and then repick it up and send it back to me, and I can alter the model. I'll show you how. Or if my doctors have this with them in the clinic, they can just use a stock tray, put this on there, get everything looted, and use a stock tray to pick this up. And this is virtually my verification jig and impression at the same time. So when I use this method, I don't have to make another verification jig because we already used this to verify things, and then we're going to use it to pour things up. Hope that makes sense, guys. It's a little, I threw you a little bit too much information all at once. I apologize. So this is what it looks like in the mouth. And let's say, for example, something like this happens, right? Where I broke a model and I need to use that verification jig to fix things. You basically would do this for the same thing. Like if in the mouth you had to reconnect it and adjust the model, the steps would be similar to this except for the gluing the base part. So if I just simply glue this model together, obviously it's not going to be passive, right? Because glue has certain thickness and everything else, and you want to make sure your models are completely passive. So in this case, what I basically did is I glued the model first and put a new base on it, making sure everything's kind of nice and strong. And I know these 4 implants are passive, and I know this one isn't. So I need to realign this implant to these 4 implants. And this is how I will basically do it. I will take that area on the stone model and I'll grind it completely out. Grind it completely out. I'll make sure that all the components are screwed in properly. And from there, what I will do is I'll mix up the same stone. I'm using low expansion die stone. In this case, I'm using GC IMP stone. It has an expansion rate of 0.08%, so very low expansion. It's a very nice stone. And I will lute that new component in there, making sure it aligns with the verification jig to everything else on that model. And from here, I'll just replace the gingiva going back, and now we have our passive model back. Okay, so fairly easy to do. But if you guys want to go a different route, let's say, for example, you don't want to do those metal verification jigs because they're pretty expensive, guys. The kit is like $1,000 and refills for each, because it's like a case with a bunch of little bars with different length, and each refill is like $45, which isn't bad, but buying the $1,000 thing initially is kind of pricey. There's other ways of doing it. Let's say, for example, you took your impression with like luted jigs and you got your final model. And make sure you do your models properly, guys. Okay, this particular case was done by one of the big box labs, and you can see that it's just all over the place. You got a huge voids in the models. The type of stone was used wasn't die stone, so it was a high expansion stone, so it wasn't passive and everything else. And this is the model that I did after that case. We already did the whole thing, so way different. You want to make sure you measure proper amounts of stone and powder. I vacuum mix everything. If you don't measure your stone and powder, and you just arbitrarily mix your implant stone, what basically happens is that you end up with stone that no longer has the proper expansion rate as was prescribed by the manufacturer. And it could be higher, it could be lower. And you want to keep things very precise. Okay. And this is how I usually make verification jigs out of stone. Why stone? Why do I use stone, either metal or stone? Because stone doesn't flex, and especially if you're doing like a zirconia hybrid, and you're going to do a verification jig that's, let's say, pattern resin, and maybe you didn't make it thick enough, and you had some flexibility, so it's no longer passive. You make a zirconia from that same verification, and you go to torque it down the mouth, that little discrepancy will snap it right there and then. So you want to be careful doing that. So here I'm using some lockout putty, which is like Crazy Aaron's thinking putty is what it's called, I think, which is basically just like the dental putty, but it's a lot cheaper. And here I'm using the Annex Den silicone to make a box. And then I'll block out the underneath with wax. Just pour wax, molten wax in there. So you have some room underneath the stone jig that's open, because if the stone jig doesn't go in there passively and ends up being fractured, you need to lute that stone jig together, and then you have to take a whole new impression. And you want to have enough room underneath that verification jig to where you can inject silicone to trap it within your impression, so to speak. Okay, you can see right here I have plenty of room underneath, and then you make a custom tray to fit on top. And if it snaps intraorally, You want to make sure you load it with either pattern resin or composite to get things done. Now, these were the first jigs that I used to make, and you can see they're not glazed. It was just regular stone. And we ran into some issues with that because stone ended up absorbing lots of moisture intraorally, and it was very difficult to load it together, and also didn't make it as precise. So what we started doing after that is we started glazing them. And by glazing the stone jigs, the moisture no longer gets absorbed. When it fractures, we clean those areas up a little bit, and we load everything together and take a whole new impression. Now, why don't we use our temporary dentures for our verification jigs and things like this? Well, because lots of times our temporary dentures don't have metal reinforcement, so they have a lot of flexibility to them, and we have a lot of fractures, things like this, so they're not very precise. So we can't use them for that. But what we can do is a method that I started doing very recently. We can actually duplicate that digitally and use it for the setup. So let's say, for example, we have a case that's been in the mouth 4 to 6 months, fully integrated. We took some final impressions. And we made some verification jigs to make sure our impressions are good. But at the same time, instead of making just a wax rim, our patient actually likes what denture they're having, and the doctor wants to duplicate that form, and they want to duplicate that bite. So what they will do is they'll do a 360 scan of that and send that to me. And from here, what I'll basically will do is I'll print a replica of what the patient has in the mouth. It doesn't always have to be perfect. You got some areas here that didn't come through, but it has. But what I will do is I'll cut the holes in the areas where the attachments are, and then I'll take some longer pins and connect things right directly to the abutment and hold it in place with some jig gel. Now, if the pin is too long, what you can do is you can cut it in half and just cut a slot into that pin and use like a slotted small screwdriver to hold that in place. I've done that before, guys. And basically everything holds in place, and you can mount those stone casts and do a full setup. So what I basically will send to the doctor, I'll send the verification jigs. If they're metal, I'll just send the metal ones. If they're stone, then I'll just send stone jigs and a custom tray, because with metal ones, if it's not passive, all I have them do is just cut that area that's not passive and reattach it and send it back to me, and I'll go in there and just grind that analog out a model and repick that up. With stone ones, you can't do that. So what I basically will do is I'll send them the stone one, and I'll send them a custom tray. So if the stone one fractures, they will load it together and send it back to me, and I'll make a whole new model, and I'll make a whole new verification jig just to double check things. Okay. Now the thing is that I wanted to mention is that the try-ins, or the wax rims for that matter, they're done on locators. So what I basically do is I have it on the slide a little bit later. I use little conversion adapters, abutments, not adapters, from multi-unit to locator. I buy them from Blue Sky Bio. They cost about $25 each, not expensive. Great for stuff like this. I wouldn't use it for permanent restorations, but for try-ins, they work great. So if you have to end up, putting up a whole new model because the setup is on locators, that little discrepancy change wouldn't affect it because it will still snap perfectly on those locators. Okay. How do I do duplication the old-fashioned way? So before I started the scanning, what I would basically do is I would just make a little putty mold like this on the model, and then I would actually attach all 4 of the temporary titanium cylinders with some pattern resin or light cure pattern resin. So I just have some reinforcement to hold things together. And I would inject hard wax through that putty so I can mount everything onto the model. Okay. And from here, we could just convert that into a regular setup. We can do it right here. And we can move forward with getting stuff designed where we need to. So basically, once you convert things, either we're doing wax rims or doing a duplication of patient's existing temporary prosthesis, from this point, you're going to have to start designing your bars, guys. And hopefully, when you did your designs, everything went great. So I'm going to show you guys a couple of slides for the new setup, which I basically just explained already. So we have wax rims. These are low conversion abutments that I use, you see they convert from multi-unit to the locator. Sorry, I spaced out and I said we're going to be designing bars, but I'm going to go back just a little bit to show you for the new setup because it's got some interesting things. And as you can see, I'm only using 3 locators, okay? Because that's enough. I just need to tripodize that bitrim or the setup. It works pretty well. Does this always work? No, it doesn't, because if you have a lot of divergence, for example, sometimes it's difficult to put all 3 where they're going to line up. So sometimes you're going to have to do screw retain. But I would say 98% of the time this works pretty well. So basically same thing, wax rim, the setup. And from here, guys, depends how you're going to move forward. If you're doing a regular acrylic hybrid, you just need to take it to this step. If your patient is super, super picky and they want to change a lot of things, even with the regular acrylic hybrid, we've done this before, you want to do a prototype. But if you're doing a zirconia case down the line, which we do nowadays, you definitely want to have a prototype of some sort. Now this prototype is not fitting to the gingiva very well, and I apologize for that. Usually it will, because this is a demo case, I kind of made it a little bit thinner. But usually you want it obviously touching the gingiva because you don't want air coming through there. It just makes it kind of weird speech-wise and everything else. Okay, and this is what we generally looks like when we do temporary hybrid prototypes. I'll print them monolithic. I'll do a gingival cutback, and I'll either fill it up with composite, or I'll do a gingival cutback and print the gingiva out of resin and just glue everything together. Looks something like this. So it has been working pretty well for us. We don't do a lot of milled prototypes. I do a few here and there. Usually when I can't find a good shade on the printed resin, or when maybe slightly more fracture prone and I don't have enough room. Let's say, for example, the doctor didn't do enough bone reduction, so the prototype is going to be not very tall. So printing stuff might not be as strong as milling stuff. But with these newer resins, like this is printed out of Pacdent titanium, or Titan, sorry, not titanium, but Pacdent Titan. So it's pretty fracture resistant, and we've had some good results with it. So I might be switching completely to print it in the near future. Okay. So now that we've done the prototypes the patient's been wearing for a while, we can either go forward to making a zirconia illustration, or if we're making a wraparound acrylic one with a hybrid bar, we need to design the bars. It's been a journey for me, guys, and if you've listened to my lectures throughout the years, you've seen me start at one point and I've arrived to a different one right now. So what I started with is I tried just to pull the teeth out and scan that so I know where to end the bar, because technically where the wax ends, the tooth will begin. So I knew if my bar went above this wax portion, it'd be into the tooth. But what happened in the beginning when I tried to pull it out, I didn't warm the wax enough, ended up breaking the wax. If you want to use this method, make sure you get yourself a dehydrator. Put the denture in there, wax up in there for like 10 minutes. It will soften up the wax enough to where you can remove the teeth and scan that portion. But there are easier ways to do this, guys. I used to use verticulators for the same purpose, and it was just a whole process. I would just reset the teeth back and use the wax and push it in place. It was just a nightmare as well, but it worked. This is the latest and greatest, version 3.0, as I say. I make these cages now. So basically this cage fits over the teeth, and I make these little grooves on the model. And this cage is used for 2 things. Number 1, I scan it as an opposing, and that allows me to see where the teeth will start. And the second thing is, once the bar is fabricated, I can utilize that cage to reset the teeth onto the bar. And what's great about these cages, they're rigid and not flexible like the putty, so it doesn't create as many changes in the bite when you're resetting the case. Because I've noticed when I'm doing things with just using putty, oftentimes I have to move quite a few teeth to get it realigned. With this, I still have to do some adjustments. It's never been perfect for me, but it's been a lot closer than doing it with putty. Okay, and I hold the teeth in place with either just using a little bit of sticky wax or a little bit of regular wax, and it works out pretty well, guys. This is what it looks like. So once I've designed the bar, because this will allow me to design the bar a lot easier, because I can see where the denture is, and when I do the scan, I'll just cut everything away except for the basal surface of the teeth, and I can see where the teeth are. So when I'm designing the bars, it works very well. Bars gets designed, I get it milled. My buddies at Elliott Milling have been so wonderful to me over the years, so they mill all my bars. Majority of my bars that are just regular like this, I design on my own in 3-shape. It's been a bit of a challenge in the beginning, but now I've got it all kind of dialed in. It works out pretty well for me. So basically what I'll do is I'll opaque the bars before we do the try-in. Here you can see I put some analogs in place, and I cover those analogs with some heat shrink that allows me to sandblast all the areas that I want to sandblast and leave the areas that I don't want to sandblast untouched. Okay, and then I'll opaque my bars. And the method that I use to opaque my bars is a little bit different. And it has been working out great over the years, because what I used to do before is I just used to put 2 layers of just regular light cure opaque, and I've noticed that the bonding of acrylic to that is not the best. And if you've been following me on social media, the case that I just showed a couple of days ago, where I'm doing a retread, and the acrylic goes right on top of the regular opaque. And I don't know if they didn't put any kind of bonding agent or something, but I could just literally, if I get the acrylic thin enough, I could just literally peel it off from the opaque without damaging opaque in any way. Okay, but with my method, what I basically will do is I will sandblast it, as you can see. I'll put some kind of metal primer. I like to use GC metal primer or a GC multi primer. There are many other companies out there, guys. This is what I like. And then I'll put a single layer of opaque, like a wash layer, cure that. Then I'll do the second layer, and when I do the second layer, I don't cure that right away. I just dip the whole thing in acrylic powder, and I'll let that powder get stuck inside that opaque. So when I cure it, it creates that nice, and you can see right here that rough area on top that allows acrylic to bond a lot better. And I've done some testing where I try to break it apart using this method and the other. So in the areas where I didn't put any kind of acrylic powder into the opaque, the acrylic just broke away from the opaque, no problem. But when I did with the powder, it would just be a lot harder to break away, and it would break away from the metal and not from the opaque, so the bond was a lot stronger. Okay, and from here I'll do the setup on top of the bar. Now some people would say like, oh, why are you doing it right there? Because wax will get trapped in there and you have some bonding issues. If you do your boil out technique down the line properly, that it's not an issue. What I basically will do is I'll do a boil out regularly, and then I'll just take the bar off and I'll steam clean it very well to make sure all the wax is gone, and then I'll use the VITA bond on it before processing, guys. Okay, so the teeth that I'm using on all of my hybrids, unless I'm doing like porcelain teeth, sometimes I've done that before. If you have a lot of room and you do like an overdenture, you can use porcelain teeth. But 90% of the time, or maybe even more, I'll use VITA Pen Excel teeth for the interiors, and I use Linguaform for posteriors. I really like using that tooth over the years. It's been really good wear-resistant tooth. They're really nice and aesthetic, and I've had good results with it. Now, the only little downside that you have is because this tooth, because it's so highly wear-resistant, it actually has, the reason it's so highly wear-resistant, because it actually has a lot of ceramic in it. Well, when you have ceramic, that is a high percentage of ceramic in something, the fracture, they're more fracture prone, right? So, and majority of the fractures that I see patients getting is when they're deflasking. So when you deflask your cases, you have to deflask them a little bit differently. And I'm going to show you guys how to do that in a minute. Okay, I'm going to explain it to you. So just something to be aware of. So you do your setup, you try it in, everything works great, and at that point you have to process your case. Now, what I used to do is I used to not make any holes through the denture teeth because it was a little complicated at the time for me. And also, if you have to reset teeth and the holes have been already drilled in the teeth, you're going to end up buying a whole new card of teeth. So now for me, it's a little bit more convenient to pre-drill all the holes through the teeth when we do the try-in, even if we have to do a reset, because it just saves me a lot of time down the line. And I know a lot of people started doing that right from the start that way, but it took me a little bit to get to that point. So basically what I used to process like this. I still use brass flasks when I do things, still the old-fashioned way. And I'll do the first pour. But when I do the second pour, what I basically will do is I'll cover the teeth all the way to the occlusal surfaces on the incisal edges and just kind of slightly wipe it so you can see just the tips of those teeth. And it's a very important part when you're working with this type of tooth, because doing a second pour like this will allow you to deflask things a lot easier. So when you're deflasking it, it will open up like an envelope, because I'll just take a chisel and go from the very back and it'll open things up. If you cover this thing completely with a stone and you go to chisel things, a lot of times you'll put undue stress on from the lateral aspects of things onto the teeth, and you can cause micro fractures, so you can chip a tooth. But doing it that way, I haven't had issues for a long time. Okay, so I boiled everything out. Here's the teeth. Here's the bar that's been taking off and has been really nicely steam cleaned. Now, what I used to do is I used to cover the areas with Teflon tape or something else. But what I do now is I use blue silicone. The reason why I use blue silicone, because you can see it a lot better. It makes it a lot easier to clean up. Okay, why do I pre-drill my holes nowadays? Because something like this came out. I tried to make my version of it early on before this came out, and we've had some success, but not the best. So what you could do is you buy these drill kits, and basically what it has 3 drills. One that goes from the implant side, and it's really thin. It goes right straight to the hole of the multi-unit. And the second one, you can't see it really well. It's kind of a step drill. It's got the small one here, and and it tapers off to the large one, and then it just has a large one to clean things up. I don't buy this whole kit. What I basically recommend you guys get is just get this drill, where it's a step drill, because you can't buy that anywhere else. And it's still kind of pricey, but it's a good drill bit to have. And the other 2 drills, I just buy them from Amazon. So I buy the 2.2 millimeter one, which is like $10.89 for a 10 pack of them. I think it's 6 pack, sorry. And the other one I used was 1.2 millimeter. So this one I go from the implant side, and then I'll go and reuse this one to clean things up from the tissue side towards the implant. And this is what I use to clean things up from the tooth side all the way to the bottom. Hope it makes sense. Oh, another thing, guys, I really like to use these burrs. Not burrs, the drill bits. Use these drill bits when I'm trying to clean up wax. When I'm doing a wax up on the bar, a lot of times I'll get wax into that channels a little bit, even though I'm using like toothpicks to keep that area open. If you just try to use something else to clean it up, it doesn't work as well. But these drill bits, just using it by hand, it goes out there very well, cleans up that hole, and it traps all that extra wax inside the drill bit, so it cleans up that area really well. So I highly recommend it, guys. Okay, so once everything's been finished, we're going to mount that back up onto the articulator. We're going to make sure that everything fits nice and well. We're going to adjust, and oftentimes what I will do is I'll actually end up glazing the denture. Okay, I'll use the glaze not on the teeth but on the gingival portion in order to create a better transition between where the DEJ is onto the gingiva. And also, when you're glazing the acrylic portion of things, the plaque biofilm adherence is not as aggressive, and it makes things a little bit cleaner as long as you do it properly. If you mess up the protocol, you can make things a lot worse. Once I do that, oftentimes we'll adjust the occlusion chair side, make sure everything's good, and then we'll do a scan and create some kind of night guard. Now this is just a regular suck down night guard, which I don't often recommend, but some people will still do them. A lot of people will just do a regular either hard soft from like Keystone or something like that, or they'll do a hard night guard just to protect occlusion while the patient is sleeping, to make sure things go well. Now, and in some cases, we'll take the prototypes that I showed you guys and we'll make full arch zirconia cases or zirconia on an eye bar. This particular case, so the prototype was designed not by me. My friends in Ukraine designed the actual digital file. I did the prototype. I printed with Packed and Titan, and once everything was dialed in, we used the same file to mill the zirconia, and my really close friend Vadim Viner did all the ceramic work on this case, and this is what it looked like for final delivery. Okay, so I think this is where I'm going to end the presentation. We still have a few minutes left, so we can answer some questions because there are usually some, and I usually leave like 10 to 15 minutes to answer some questions at the end. So hopefully this has showed you some things. If you viewed my presentations before, there's a lot of information there that I've said before, but there's always something new that I try to add because we always try to progress, we always try to get better, and I try to share that with you guys when it comes along.
All right, thank you, Eugene. Eugene has been gracious enough to let us go ahead and have you get in contact with him or an email through his website and so forth. But as far as questions go, let's look at what we have. And I'll stop sharing there. All right, we've got how do you design the cages to reset the denture teeth?
I actually have a video on YouTube that it shows how to do it, but I'm gonna explain it to you a little bit here, just so you can get an idea. So basically, I will make those little divots around the whole area of the landing area of the denture model, of the master cast, I mean, and then I'll scan that together with the setup in articulator, just all as one piece. Then I'll take that scan into 3 shape, and then in the custom tray module, I'll make a little custom tray that fits just right over the teeth with the holes in it. Okay. Then I'll export that file out and bring that file of the custom tray and the model into Mesh Mixer with proper alignment still. And then in Mesh Mixer, I will add posts that fit into each one of these holes. And I'll do Boolean subtraction of the model from the cage, making sure that it just creates that little nice adaptation. But there's a video of it on YouTube, or if you just want to message me, I'll send you a link for that video. It's actually not that complicated. It does take a little bit of time to get used to it, but it's such a great way of doing things because you can, if you still have the model down the line, and let's say, for example, you want to do like a retread, you can just print another cage, stick some new teeth in there, and just reset everything on the bar a lot easier as well because you always have that digital file and you can reprint it down the line. Okay.
All right. Another question is it possible to make the metal bar with Easy Bar and deliver it to the patient's mouth permanently?
It's kind of a loaded question. Is it possible? Absolutely. Is it recommended? Depends. It depends on your budget, depends on your local laws, and depends on what you're trying to achieve. Basically, when you're cementing a bar to a temporary titanium cylinder, it's not as strong as having a monolithic structure. Okay, so that would make it slightly weaker in some areas. Is it a lot stronger than not having any kind of reinforcement at all? Yes, absolutely. So my personal recommendation, if you want, I would probably use that for a long-term temporary, but as a permanent structure, you might be able to get away with it, but you obviously would want to charge less for this as you would do for titanium because they're not getting as much value out of it as they would with the titanium one. Just in my opinion, but I could be wrong.
All right. Do you duplicate the denture while the patient's in the chair? What is the fastest way to do in analog?
Analog is the fastest way to do an analog is to use a duplicating flask. If I could share my
Like an old Lang duplicator?
Yeah, using a Lang duplicating flask. Where is this darn thing? Can't find it now, sorry. But yeah, I use a Lang duplicating flask, and I basically will block out the undercuts inner-length duplicating flask with some stone, because if you use putty in there and not alginate, that putty gets into those undercuts, and good luck digging it out. Unless you just want to buy a new length flask for every duplicate, I would definitely block out those undercuts. And don't use alginate, guys, because especially if you have a taller ridge, it just deflects too much, and it makes it more difficult. But honestly, nowadays, if you're a clinician, just use your intraoral scanner to do a 360 scan. If you can't do that, majority of the labs will have a lab scanner like I do, and oftentimes if I'm nearby, I'll get a phone call like from the residency, like, hey, we got a case, we can't figure out the intraoral scanner. Can you grab the case and do it in the lab? And I'll usually do like a 1 day turnaround to scan the case and give it back to them. And that works out pretty well. Nowadays with digital, duplicating stuff is so much easier. I will often just, case the other day, I got a patient that wasn't sure about their dentures. We did a regular wax try-in. They're like, oh, I don't know, is it too tall? Is my bite right there? I said, you know what, don't worry about it. Let's do this. I took the case, scanned that in, printed the whole thing out of try-in resin. I used packed in try-in resin. Gave it to the patient, have them wear it for a couple of weeks. So see if you like it. If we want to change something, we'll change from here, which is a lot easier than having to do a case and then the patient comes in and goes, yeah, I hate this thing. And you have to remake the whole case from scratch. So this makes things a lot easier.
Yeah, the digital world certainly is changing the options
Oh yeah.
on how to get the right bite and everything. So
Yeah, I mean, it's been such a blessing clinically for us that it's just, but it doesn't replace the skill. Like if you can't
right,
take a good impression by hand, you still can't take a good scan. I've seen really bad scans, I've seen really bad impressions, and vice versa.
yeah, good data has to be good data.
Yeah, no, yeah.
Garbage in, garbage out. So
Garbage in, garbage out. That never changes.
I know. If you had a go-to attachment, what's the first one you usually see if you can use an
If I
attachment?
had to go to what? I'm sorry, I didn't hear you.
A go-to attachment, the
Okay.
brand. Is there a go-to attachment you try to use, or is it matter case by case?
It's matters case by case, but two of the main things that we generally do, if we're doing a screw retain, I really like to do screw retain on multi-units, because even though it takes up a little bit more room, because you need rooms for components, right? If you're not going straight from implant level, you need room for the multi-units and so on. It really allows you to correct some divergence on the implants, on the implant level, and you correct it with abutments. And also, if you're having some issues with fracturing and stuff like this, you can always just replace the abutment without having to worry messing up the implant. And because majority of the bars that we make, they're milled in the center, right? And those bars are made to fit some type of connection. And multi-unit abutments, they're milled in the factory to certain specifications, right? OEM manufacturing. And I know that that is made to fit precisely into the implant. Well, technically it should be. But the bar, sometimes things will happen. So I'd rather make sure that my connection to the implant is going to be perfect from the OEM manufacturing, and then I can connect from there to the abutment using a bar and not having to worry about some issues with getting best adaptation. When it comes to other cases, I oftentimes will do either locators or equators. Even though equators are slightly smaller, I'm still a fan of locators just because it's been around for a while and I've had good results with it over the years and I know ins and outs of that system. It's just a personal preference. I'm not
Yeah.
sure if there's any kind of technical explanation behind it.
And then last question. There's a couple questions about where do you get your barium sulfate? I assume it's a powder that you mix in. And
Yeah, it's a barium sulfate powder. You know, it's been so long since I've done this. I got this, I think I got it on eBay back in those days, which I probably shouldn't say because I'm not sure. Well, I can't remember. I'm sorry. Nowadays, I've done that barium
yeah,
sulfate like once or twice, so majority of the times I will do things like this. And actually, after I've done it with barium sulfate, now you can actually get radio opaque resins that you can 3D print, so you don't have to use the powder.
uh,
Because powder is kind of clumpy and it's really hard to mix it to the acrylic. It was kind of a nightmare. To be honest with you guys.
Yeah. Exactly. Well, thanks, Eugene, and those of you that are joined us for today. The information for Eugene is on the screen.
Except for
Please,
the QR code, guys. The QR code is
yeah,
old.
the QR code I'll change now that you got a new one, and we will, you know, have this posted as well. I'll have our guys change out that barcode so it's the correct one online. And I want to thank you very much. Any last thoughts on this topic, Eugene? You want to give the audience?
Yes, I do want to mention, guys, that make sure you communicate properly with your team. And when I team by the team, I mean if you're a clinician, talk to your tech, talk to your oral surgeon. If you're a technician, make sure you voice all your concerns about cases, because if you get it all pre-planned, it's a lot easier to fix some small issues down the line. But if you kind of wing it, or if you go backwards, there's a reason why it's called prosthetically driven implant placement. Because if you go the other way around, guys, it's always ends up being a nightmare.
All right. Good, good final words. I appreciate it, and all the time, and the way that you educate all the technicians and denturists. Of course, you are getting there right. You're just about got your denturists. Everything's all squared away with that. You're
Oh,
going
I've
out.
had it for a while, actually. Yeah.
Yeah. So you come from a perspective in which a lot of customers appreciate because you delve into both worlds, right?
Yes, I
Denture,
try to dabble in both clinical and laboratory aspects of
yeah,
things. Yeah.
which is nice. So, all right. Well, I want to thank everybody for joining us today. And
Yes,
again,
thank you, guys. I really appreciate you coming.
you are very welcome, Eugene, and appreciate all your time and hard effort you put into this webinar, this presentation today. So this will end today's VITA webinar. So thank you very much for joining us, and we hope to see you again on another webinar in the future. Thank you for attending, and this will end today's webinar.
Bye, everybody. Thank you.